All right, we're here at the IAS meeting. We're here with Glenda Gray, who's graciously allowed us to spend a little time with her in a rush. But we wanted to cover the work.
Sure.
You're with the National NIH, associated with the National NIH, and you're the director of the.
I'm the
South
president of the South African Medical Research Council. I'm also the co-PI of the HVTN, which is the
right.
HIV Vaccine Clinical Trials Network.
So, which is what we're going to talk about. We're going to
Sure.
talk about vaccines because it seems very interesting that we have something that is coming along very decently, and we don't know exactly where it's going to be, but we have some ideas. But can you give us the background on this vaccine approach?
Sure. So 6 years ago, we, after the RB144 showed moderate efficacy, we got together as a group of people and said, well, how can we try and replicate these findings in an area of the world which was hard hit by HIV, and that was in sub-Saharan Africa. And so one approach would have been just to take the RB144 study and stick it into South Africa to see whether we could achieve the same kind of vaccine efficacy. But because we have a clade C epidemic, we wanted to optimize our approach. HIV vaccine trials are incredibly expensive, and so you don't want to throw money down the drain. And so what we thought we would do is optimize the regimen further. And so we made it clade C specific, and we manufactured a new protein and a new adjuvant. And the whole aim was to make the vaccine appropriate for South Africa, but make it more potent and make it more durable. And so this is how we try to improve on the findings of RB144.
Now, is this compound, something that's more specific to the population?
Exactly. So we took circulating strains from the clade C area and put them in the viral vector. When we were designing the new protein, we took a prevalent HIV strain from a chronically infected South African, and we also then looked at an acute HIV, the serum from someone who was acutely infected with HIV, looked at their envelope and chose an envelope which was very potent in terms of activity. And so by choosing a prevalent and choosing a prevalent strain and an acute strain, hopefully we'll maximize a broader cover to the envelope of HIV that people may be exposed to in South Africa.
So your expectation is 30, 50%, somewhere in there?
Well, we will have the power to look at for 50% efficacy. Based on our modeling and based on the kind of responses we got in HV10 100, we estimate that we would get at least 50% vaccine efficacy.
So those that would not be efficacious for, what would the difference be between them and those who it was?
Okay, so when you enroll into a study, it's a placebo-controlled study, and so what we do is we compare people who get standard of prevention plus the vaccine versus people who just get standard of prevention, and then we look to see how much more protection did the vaccine give with standard of prevention. And so for participants in our study, we don't want anyone to seroconvert. We don't want anyone to become HIV infected. HIV infection is a devastating disease. And so we equip people with as much as information to protect themselves. But we do realize that what happens is that sometimes you don't have your condom with you, you might forget to take your PrEP. Life happens. And in that period of time, standard of prevention may fail you. And we'll be able to tell the difference between standard of prevention that failed you and the vaccine that you happen to have on you at the time when you were exposed.
But would you know what physically, what anatomically, or what genetically, or whatever the issue is that person that failed, why they would have failed?
So we're very interested in that, trying to understand what we call breakthrough infections. And so one of the reasons why you may have a breakthrough infection is that the antibodies that you induced or your immune response that you induced did not cover the strain of HIV that you got. So what we do is that everyone who seroconverts in our study, we rapidly look at the virus that caused the infection. We look to see how it interacted with the vaccine, and we look to see how the breakthrough happened. And so, to try and understand the genetic modification that the virus had to do to overcome the vaccine-induced immune response.
So would it be useful for you to have that information to define who it is going to work for and who it won't be?
Well, it will be useful after, as we start to understand the results of the studies. So then we look, and we do it with all our HIV vaccine studies. We study the viruses that evolve after being exposed to an HIV to try and understand how vaccination altered your immune response. And in some of the previous vaccine trials, we have actually identified some novel neutralizing antibodies that we can then use for future interventions. And so understanding how the virus overcomes your immune system that you produce from a vaccine, how it overcomes it, helps us understand how to make better vaccines. So if we knew how it overcomes, then the next time we can make a vaccine that hits it somewhere else. Or you might use a different approach. So you might prime with a certain intervention and then boost with another one to try and bring a very balanced and varied immune response to protect you from all kinds of strains that you may be exposed to.
Or there may be people that this vaccine, up front, would not work for.
Well, we don't know. We would not know that. Yeah, and we would learn that. So as we've understood antiretrovirals, say like some of the antiretrovirals, we've learned that certain gene profiles, that doesn't work for all. It could cause susceptibility or adverse drug reactions and that. So it's very important to try and understand the interaction of the host. So every person has a unique genetic code, and that genetic code can help us understand why you're susceptible or not susceptible to HIV, and how your genes influence your immune system to respond in a certain way to a vaccine. So if we found that the vaccine worked and there was a certain group where we could not understand why it didn't work, we would definitely look at the epigenetic components to try and understand further the interaction between the host, the virus, and the vaccine.
So you're going to educate the people about the fact that this is not going to be a guarantee,
yes,
and so forth. You'll describe it in a way that's appropriate.
Yeah.
But the important thing is that people will know that they're going to have an opportunity to add to their compendium of prevention. And even though I think there was some discussion, of course, it would have been my question regarding the efficacy. I mean, 50% is not great. 60%.
Well, we started with,
but it's a part of
it's the beginning, So we have to, if we knew a vaccine regimen would work, we wouldn't have to do the study,
right?
And so these trials, they help us to understand whether what we're pursuing is the right approach. And we tell people that you have to know that this is experimental. Whether it's a microbicide or a vaccine or a passive infusion of antibodies, we don't know if it's going to work. What we do know works is condoms, medical male circumcision, access to PrEP, and so we don't want to people.
But even male circumcision doesn't work.
Yeah, it's hot, and we still do it, and we still write it out.
So
and so that's
go.
the same. Medical male circumcision is a moderately, partially efficacious intervention. PMT-CT was, AZT, nevirapine were partial interventions that potently helped us bring down transmission rates, and so they're valuable tools. If I could reduce my risk by half by taking a vaccine or a pill, I would do it.
And then half again with the other.
Yes, and then obviously two. So you want that tool to be working when everything else fails you, or when you fail yourself because you're not empowered to use a condom.
Well, what are your next steps?
So the next steps is to rapidly enroll into the study, so that we can aggressively follow our timelines, so that we can be able to tell the world as soon as possible whether this vaccine worked or not, so that we can get it into the next step, which would be the regulatory path to licensure. So it's manufacturing, it's understanding the correlates, it's bridging studies to adolescents, to other populations, and it's trying to reduce the regimen and make it more potent. And so the next steps are incredibly important because it helps us bring a vaccine into the clinic that's easy. We have to look at refrigeration, and so obviously one of the steps we'd be looking at is, can we make this without using a fridge? Can we mix it like this? Can we make it up in the clinic? So those kind of questions about scalability. How do we take it into real world?
Well, it's been very enchanting here speaking with you, because I know this is something that's going to be worthy of looking at it and see where it's going. And
it's a long road, I was here, I've been working in HIV since '93.
I know.
First as a pediatrician, first in mother-to-child transmission. We've come a long way, and we've got to kill this thing. We've got to become more smarter than the virus. We've got to outwit him with calling it a him. We've got to outwit the virus, and we have to find tools that are radical, aggressive, and are consistent in trying to prevent the acquisition.
You're what I would call a key researcher advocate, so it's appropriate that we have you here and doing this.
Well, I feel
this
passionate,
pitch.
having worked in the clinic and having been exposed to such a horrific epidemic, I'm passionate about finding a solution, because a solution to be able to. I started off my medical career not knowing HIV, and to end my medical career,
It would be nice to have some success.
not knowing HIV anymore. It would be wonderful.
I think that we've had that discussion with a number of researchers, and it's so, we feel it's so close, and yet it's yet elusive.
Yeah. But if you look back for 16 years, so I wasn't even thinking. It's only when I started to think about this conference and where I was in 2000 did I see actually. Sometimes you think we haven't done anything, and then when you look back and you think,
Oh yeah.
gosh,
30-some drugs.
people are living. Babies are not getting HIV.
In the
we have
old
more
days,
prevention than we had in 2000.
Before treatment, it was a very grim.
It was grim,
day.
it was grim, and so yes, we take this conference in 2016 and say, yes, we've done good, but we need to do better. So good. Pat yourself on the back, but the
And we
race
also
is
have
not
to figure
over.
out how to do more with less,
Yeah,
because
exactly.
the resources are drying up. So this is our plea to get the governments to fund. All governments should be funding this research.
All governments should be funding research. All governments should be funding treatment. All governments should be committed to interventions. This has a devastating effect on their citizens. It doesn't make any sense to turn your back on your citizens and not fund stuff that's going to help them.
Glenda, thank you so much.
Pleasure. Thank you.